Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me for the Conversation with Cancer Experts series, Dr. Krina Patel, who is a multiple myeloma section chief and research lead at a center that requires absolutely no introduction, the top-rated cancer center in the United States, UT MD Anderson Cancer Center. We're really privileged to have her. Welcome, Krina.
Thank you so much. I'm really excited to talk about my favorite things today with you.
Yeah, so you obviously were the discussant at the ASCO meeting on some of the key abstracts that were presented there. So you gave the expert opinion. So we'd like to, once again review how you saw some of the key research presented there. So to start out, obviously your, overview was focused on the BCMA CAR-T cells, and it was in two disease states. There was myeloma and some of the first data to emerge in amyloidosis. So to set the stage, so where are we with cilta-cel in relapsed refractory multiple myeloma? That was one of the key presentations that had a lot of conversations going, both in the lay press and in academia.
Yeah, no, I think the late present, like what the final sort of 5-year progression-free survival, which I think we're going to talk about soon, was really exciting because in myeloma we used to say we didn't really have functional cures except for those patients who got stem cells and then weren't on maintenance for at least 5 years and did well, which is great. But again, the majority of our patients stay on treatments forever, so I think that was really exciting to talk about, and I still talk about it probably every other day right now. But this is just sort of a slide showing where we started in CAR-T. I will say when I was a fellow more than a decade ago, I won't say how much more than a decade ago, but I had a lot of my colleagues, my mentors that weren't necessarily in heme, but they really thought that we wouldn't be able to target CAR-Ts, myeloma with CAR-Ts or immune therapy. They thought that, myeloma doesn't have these antigens. It's sort of in the middle. It's not like renal cell or, melanoma. Little did they know that there were already targets being found, and we were finding all these different ways to go after monoclonal antibodies. But CAR-Ts really came out in the last 6, 7 years in terms of clinical trials, and so we have the ide-cel as one, cilta-cel as the other. And I'm just showing some of the KarMMa and CARTITUDE-1 data here. And then the last three, of course, teclistamab, talquetamab, elranatamab. We have our bispecifics that, again, are a little bit easier because they're off the shelf, but maybe not as potent as the CAR-Ts, where we see a lot higher response rate and deep responses, and again much more MRD undetectability compared to our bispecifics. But again, just really awesome, and I think we also have more targets like with talquetamab, GPRC5D rather than BCMA, and of course there's so many more coming down the road. So again, this was just sort of that. Hey, look, that cilta-cel median PFS is 35 months almost, and to have it in a one and done patients who had 6 lines of therapy, no other treatment, I think that's pretty impressive.
So obviously this is the slide that caused all the conversation. So what's your takeaway on this?
Yeah, I think, I wish it was higher, but to even get a 33% plateau, as we like to call it, I hope it goes on forever. I always I don't hold my breath because myeloma tends to come back in all our patients, but I think this is really impressive. I don't know of any other therapy in this line of, when patients have this much treatment that can do this. And again, quality of life for these patients are so great because they're not on treatment. Their myeloma is completely controlled. So again, some of these patients were MRD undetectable even at their 5-year mark, but we need more studies that prospectively look at this. And I think, but to finally say we could have a functional cure as a potential for our patients is really, really exciting.
So what you did, as each discussant has to bring out some of the limitations. So what were the limitations?
Yeah, and of course, right now we have mostly comparisons to historical controls when we talk about what would have other patients done if they didn't get, because this is not a randomized study. And so, CARTITUDE-4 is the randomized study. So I'm hopeful that we'll have more data in another couple of years. They'll be at 5 years. So we'll see then. But right now we don't have any other data to look at. So we look at historical controls in terms of, is this better or not? I think 5 years is pretty impressive, but again, I'm looking at side effects, and trials, especially CAR-T studies, tend to give us eligibility criteria that are really strict. So patients have to be in pristine shape or, have really good counts. Their kidneys can't be too bad. They can't have other major comorbidities or health issues. So when we get in the real world, we'll start treating patients, with kidney function issues. If they're in dialysis, we'll do it. And so I think the trial looks great, but we need more, I guess, inclusion to really say, is this going to be like this for everybody? Or is the toxicity potentially higher for certain patients where we shouldn't be doing it? And I think the really interesting part was that when they looked at this and said, who are the people that got to 5 years, right? Was it everybody or was it low risk patients? I think the important thing was that most of these patients already had 6 lines of therapy. So they're likely all high risk at that point, one way or another. But it was actually interesting to see. It wasn't powered to show this, but at least trending that patients who had lower disease burden, and what they used was soluble BCMA, and then they used bone marrow involvement, that those were the patients that could still do really well, even if they had high risk EMD, et cetera. They could still get 5 years as long as they had less myeloma. And I think that's great, but we just need to have more numbers to be able to prove that. But I thought it was really, really interesting that they actually tried to see who are the patients that were able to get to 5 years and who weren't.
So there are obviously some toxicities with these treatments.
Yep. So I would say CRS and ICANS, we don't see as much, but again, those who have a lot of disease going in, they tend to have more issues. So yeah, bridging therapy is really important. And so if a patient has late line myeloma that bridging doesn't work for, they could end up with, high grade CRS or even something called IECHS or HLH basically. And those are really hard to treat, and patients don't get that quality of life that we were looking for. The other big ones that we see in myeloma CAR-Ts, of course, are the delayed neurotoxicities or the motor neurotoxicities, the MNTs. And in the study that we're seeing that long-term data for, 6% of patients had Parkinsonianism. And this was something that, a couple of patients died from because of it, and they were wheelchair bound. And again, opposite of that quality of life that we want. Thankfully, in the earlier line studies, we don't see it's 0.5%, but still, I think things that we need to look out for and really discuss with our patients. Secondary cancers, of course, that happens to our patients in myeloma, and especially as people are aging, but 18% total secondary primary malignancies, 8% were MDS AML, and then there's a 6% non-relapse mortality. So patients who actually were in remission but died, and again, usually to these toxicities, I want that to be 0%, just like we kind of are at with transplant right now, right? So I think these are things we definitely talk to our patients about. And then the need for a caregiver, the time toxicity. At the time of this presentation, it was 30 days, but maybe just a couple weeks after, the FDA actually came back and changed the rules. And so now all CAR-Ts are only 2 weeks. So technically, the patients only have to stay at the local center, the centers where they do CAR-T for 2 weeks. The driving restrictions are now 2 weeks. I will say for cilta-cel, though, because usually the CRS and everything happens in that second week, we've made it 3 weeks. So again, those 3 weeks can be a little bit harder for patients that don't have access. They're not from Houston or from St. Louis, where they can just go in and get their CAR-Ts. If they're 2, 3 hours away, there is some time and financial toxicity that can happen too.
I know not in this trial, but something you've reported on more recently is emerging story around delayed toxicity with colitis. What can you tell us about that?
No, that's a great point. So yeah, we actually just had a grand rounds yesterday at our CAR Talks meeting and had Dr. Milkanani from Stanford present on this too, because she's sort of leading a consortium to figure this out. But yeah, we have these patients that have colitis, and it's not just diarrhea. It is profound diarrhea where they're getting hypokalemic, losing, kilos and kilos of weight really fast, not able to absorb or keep anything down. And when we do biopsies, these patients don't have a lot of, active inflammation. So some centers have been able to find some CAR-Ts with different flow and, other tests that they're trying to do. Some centers have actually done, even more profound work with single cell RNA-seq and TCR clonality and all of these things. And again, it's different for different patients, but for the most part, these T cells for some patients take off. They just sort of, turn into, we don't know if it's a lymphoma or leukemia or these T cells that just had a clone that really went, faster than we expected, and they stick around. And so we think they end up causing issues with inflammation in the gut that then leads to this toxicity. Thankfully, for two of our patients recently, we were able to give high dose Cytoxan and just sort of killed the T cells, and they got better and they got out of the hospital. They started eating, and the diarrhea resolved, which is great. But again, that's not something I want to do. So we're trying to learn more and more about who are the patients that are at risk for this. And is there a way that we have a biomarker? So this question about this ALC, the absolute lymphocyte count, right? With cilta-cel, when patients expand, you'll actually see it in their blood count. The absolute lymphocyte count will jump. It'll start going up. And when it gets to 3 to 5, we always wonder, is this someone that's going to get the neurotoxicity or the colitis? And we're all trying to figure that out right now. But Colorado, for instance, they'll give steroids to try to knock that down. We don't have long-term data to say if that works or not. So at MD Anderson, we don't do it yet. But the second my patient has neuropathy symptoms or, colitis symptoms or anything like that, we are going to be a little bit more aggressive of trying to find out what it is and treat it appropriately if we need to, if they are having symptoms. The steroids issue, it's when people have colitis, the steroids do help them feel better, but if they continue on steroids, most patients end up with perforations or sepsis or infections. And so we're trying to avoid steroids and find other ways. We are trying, our GI specialists have their drugs that they use, their antibodies for, Crohn's and ulcerative colitis and all these things. And we've tried those. It seems to help for a little bit, but it's still not enough for the majority of our patients. So again, trying to learn about that. Thankfully, it's less than 1% of patients, but still something important that we talk about. And it kind of goes along with that secondary T-cell lymphoma leukemia, like a CAR T-cell leukemia or lymphoma, that we've seen these case reports about, and now we're trying to put it all together. So there is some association with the gut and these lymphoma leukemias that we're potentially seeing.
So in your presentation, you also touched upon some of the real world data that has emerged.
Yeah, so again, in the late line, we haven't done as much in the early line yet because that data is maturing now in the real world. But again, 54% of these patients with cilta-cel that we have from 20 different members of our consortium around the country, 54% wouldn't have been eligible for CARTITUDE-1. And again, for most, the reasons are their counts were too low, their kidney function was off, some kind of organ dysfunction, or many had prior BCMA therapies, which was not something that was allowed on CARTITUDE-1. And so with that, 19% also had out of spec products, meaning that they were able to manufacture the CAR-T when we took out their T cells, but when it came back, it didn't fit every criteria that the FDA is required for it to come. So we don't have data yet on that that's been published to say, do those patients do just as well or not? But again, those kind of factor into when we compare to the studies. But again, median follow-up was 13 months. And my colleague Surbi Sadana from Stanford, recently this paper got published. And again, in general, the response rates were still pretty awesome. We're going to talk about that next. But in terms of toxicity, it wasn't horrible. It was actually a little bit less CRS. We tend to give more toci and dexamethasone early. The trials usually gave it when it was grade 2, and then the real world, we do it at grade 1. But we did see more of the delayed neurotox, not so much the Parkinsonianism, but more the cranial nerve palsy. So, these aren't fatal, but they do require treatment with steroids, IVIG usually for a little bit, and they can take weeks to months to get better. But thankfully, the majority of all our patients, 99%, it's resolved. And so again, just new things we're learning. And again, this HLH, we didn't know about it as much when CARTITUDE-1 was happening. So it might be that we're just learning to diagnose it, but still in these really late line patients, they're just more likely to have higher inflammation that we just have to start treating then.
So what about the efficacy then?
Yeah. So again, really great efficacy. If you look at those patients who are conforming and they got fludarabine and Cytoxan. So remember, during COVID, there was a shortage of fludarabine for a little while. So a lot of centers used alternatives or bendamustine. So we didn't want to use that because obviously that can change things. So patients who had in-spec products got fludarabine and Cytoxan, their response rates were still really high, as you can see at the very right of that first graph, and stringent CR rates were still really high. So it's actually pretty similar to the trials, a little bit lower, but relatively similar for this patient group. And we haven't hit that median PFS yet. I think it's going to be lower than the 33 months, but still pretty impressive for a 54% of patients who wouldn't have fit eligibility criteria and still, are able to get a one and done. And it's, it's probably, I have a feeling it's going to be over maybe 2 years, but we'll see when we get the longer term data. But it was still, it was impressive to see it wasn't 6 months or a year, as, sometimes we'll see a big difference in trials versus real world.
And what do you expect as you move it into earlier lines?
Yeah, I think the question is, what there's been an argument that, oh, well, if you do so well, 33%, they're 5 years out and you can do well, why not just wait till the end? But obviously, a lot of our patients can't get to CAR-Ts by fifth line. Their disease takes off. They don't have good bridging. They end up with bad infections, what we talk about when patients just can't make it to that next line of therapy and attrition. So here, this is why, we don't ever do this by comparing, but this is why we're just hypothesizing that so far, CARTITUDE-4, which is early line, so second to fourth line treatment in Len refractory patients, so far at that 1 year mark, 3 year mark, et cetera, that 30-month mark, as you can see here, there are definitely more patients that are still in both overall survival and PFS than the CARTITUDE-1 patient. So I'm hoping at 5 years we'll see a bigger plateau, but we need that data.
So, what's coming up among other products in the CAR-T realm?
Yeah, so I think this is a great start. This was the first generation of CAR-Ts that made it for myeloma and BCMA. We do have a couple of others that use BCMA as the target still. So the anito-cel data has been pretty impressive with greater than 98% response rates, 100% in their phase one. It's easier to make that. It's a different scFv. They don't have the neurotox or the colitis, that we've heard about yet. Hopefully, it'll be approved in late line in, let's say, spring. I'm hoping, since the phase two data has already been presented, but we'll see. And I think, Kite is the company that's making it, and they're really good at CAR-Ts, and they can usually get the cells to you. And so we'll see what the out-of-spec rates are. All that kind of stuff will be interesting. Then we have the fast CAR, which is even faster production, and it's CD19 and BCMA CARs. There's a lot of data from China that's pretty fantastic. I would say the toxicity is so much lower, and not just the delayed neurotox or not seeing any colitis, but even the CRS and the ICANS is a lot lower. The studies have just started here in the US, and I will say I've been very impressed so far with my patients that have been on there. We'll see, the big data, hopefully the next year or two. And then, of course, we have other targets, the GPRC5D, so Arlo-cel. So can we not get the nails falling off and skin falling off and taste changes and hopefully, goes away because it's a one and done? We'll find out. And then, of course, allogeneic CAR-Ts. This was something I was really interested in a while ago. I don't know, it's off the shelf, which is nice, but a one and done, just like other CAR-Ts, we haven't found the route, I think, the right sauce yet to be able to say our allogeneic CAR-Ts are as good as our autos. But I'm hoping in the future, especially with some of these in vivo and mRNA things that people are looking at, technology where you don't have to even make the cells, you just get an injection and they go. It's very futuristic, but again, 10 years ago, CAR-T seemed very futuristic to me.
I agree. Wouldn't that be great to just get an injection? So, moving on to another disease that is a little more vexing and sometimes frustrating to treat, amyloidosis. So, I guess we had one of the first presentations of CAR-T in this disease entity. And what was your take on that?
Yeah, so I think, yeah, we all have patients with AL amyloid, and thankfully patients are being diagnosed earlier and earlier because internists are recognizing to look for it when patients have certain symptoms. But really, we don't have as many therapies. First line, we have our Dara-Cyborg from Andromeda. And then in second, third line, you see here, there's so many different options, but really there's not one particular thing that we all use. And so I think having a BCMA therapy, because again, in AL amyloid, it's the plasma cells, right? They're causing this amyloid deposition. We want to go after those plasma cells. And having a BCMA therapy makes so much sense. When people told me they were doing CAR-Ts, it worried me a little bit, especially with our cardiac amyloid patients or even our patients with renal amyloid, which is a lot of them. People get volume overloaded. So if you get CRS and you need fluids, what's going to happen? But I think this study actually showed the feasibility and safety, as well as some pretty great, response rates that they have.
So, what was the efficacy?
Yeah, so here, I think they changed it a little bit, but they changed it on me when I was presenting. But yeah, they still had a real, it was about 10 patients, but seven CRs, one VGPR, two PRs. MRD was undetectable in 9 out of 10 patients by day 25. So that fast, we see that deep response early. And then this was what really surprised me, that you actually had organ response for 5 out of 6 patients, right? So it wasn't just, okay, hematologic response, great. We killed the plasma cells, we see the M protein and the light chains go down. But to get organ response, kidneys, heart were the two most that were included. I thought that was great. We don't have long-term data yet, like in terms of PFS and toxicity, even long-term. But again, I think this is pretty phenomenal data for the first few patients on the study.
Yes, certainly. So, what do you think is going on? Because most of these patients, yeah, I can understand their marrow getting cleansed out pretty quickly because they have somewhat small volume of disease, but organ response is to be seen within the first few weeks. Do you have any idea as to why that may
Oh,
be?
no, I mean, again, is it, how are we getting rid of the amyloid, right? I mean, because that's been the thought process of why we're trying to get, you know, um, other treatments that actually go, for the amyloid fibrils, and we haven't been able to yet. And so to have patients reverse, we know that when you actually treat, patients do have a little bit of reversal. But again, these were relapsed patients. They weren't, first line. So again, to have really good organ responses, I don't know the mechanism of action. I don't know if it's we kill the plasma cells and some of the cytokines that plasma cells make. We have a deeper response. So whatever that was causing it, maybe it's not the amyloid deposition. But again, it would be great to see biopsies and see if there's really a decrease in that amyloid, or is it something else that we don't usually test for that goes lower and then patients actually feel better. I will say I have patients on some of the bispecific studies right now. And again, even with the first dose, all of a sudden their swelling goes away. They feel amazing. I'm like, what? I don't know the way why, but I've seen it with other BCMA therapies
Oh,
too.
interesting. That's very interesting. So, what are the limitations? What are the questions you have?
So obviously this is only 10 patients and follow-up was 131 days, but still we need longer term follow-up. Some of the patients that were missing were like there wasn't anyone with GI involvement of amyloid on here. There was one patient on dialysis, I think, or had grade or GFR that was low, but not dialysis when they're going on to the study, which a lot of our amyloid patients obviously do end up on dialysis. I don't think anyone had co-diagnosis of myeloma. And again, there wasn't a lot of information on how long did it take to make the cells. Is it different for amyloid patients? Did they get bridging therapy? We talk about bridging therapy so much for our myeloma patients, and do we need to do that to help with kidney function or anything like that? And then the toxicities, they were pretty minimal. But they didn't talk about volume overload, which was my main question. Like, did people get volume overloaded during the CRS, and how did you manage that? And maybe they didn't, but I guess that was a part that wasn't really on there. And I think, again, the significant renal insufficiency, that one patient didn't do well and had some issues. So what was the fludarabine dosing? Are there ways we can still make it safer that patient or patients with renal insufficiency could still get the cells, but maybe we need to figure out the expansion and maybe decrease the LDC chemo or whatever we need to do. So again, fantastic data, but lots of questions just because it's only been 131 days.
So, what are your key takeaways from the presentations in that section that you reviewed?
Yeah, so I think the fact that cilta-cel, the biggest thing that there was a New York Times article that came out too on June 3rd, and a lot of my patients have read it and they've asked me about it. And I think the fact that 5 years out and you can be without myeloma in a relapse refractory state and actually feel well and not be on treatment is pretty impressive. So functional cure. And then I think for AL amyloid, again, we always borrow from myeloma, but sometimes some of the drugs or some of the treatments seem a little bit too toxic. But to see that the CAR-Ts actually, even for patients that have organ issues with AL amyloid, can actually do really well. I'm excited to see the long-term data. And then, access and toxicity prevention are really our unmet needs. And the FDA recently helped with some of the access issues, and now it's just how do we help with the toxicity prevention.
So I really want to thank you for taking the time to educate our audience about some of these key presentations at the ASCO meeting. And I look forward to having you back on the program to talk about new developments as they occur.
Oh, fantastic. Thank you so much.
Appreciate it.